Hi, welcome everyone. Thank you very much, Sheila, for this introduction. My name is Daniela Masters. I'm the head of Global Health and Wellness Programs at Generali Employee Benefits. We are, as the name says, an employee benefits network. So we work with about 60 local insurers, health insurers around the globe. And welcome to this session. We actually have a little poll on Slido. So I'm always interested in understanding. Do we have the poll? So I'm always interested in understanding which goals are driving your investment for health and well-being initiatives. So if you had to choose one of these from a strategy point of view, is it changing lives, so really altruistic? Is it elevation of the EVP, so your brand? Do you want to reduce absenteeism or presenteeism? Or do you have a financial focus, so you want to impact the health insurance premiums? So I'm going to wait a little longer. Okay, so we're seeing a really, we're seeing that it kind of goes to changing lives and really brand, which is very interesting to see because there's definitely a big financial piece to this as well. So we always or the executive level always wants to know why should we invest into health and well-being, and maybe then also how can we measure it. So going back to our to this presentation, I want to show you a little bit of insight on how we look into data and how we work with our clients and how we try to help them understand the data. And I'm going to give you an example by an actual case study as well. So as many times mentioned today, there is a wealth of reports available for us in the companies that we can use to actually find the drivers for health and well-being initiatives, but oftentimes we just don't know where to find them. We don't know who has the reports. We don't know how to read them, or we don't know how to use them effectively. So can I just have a few examples what you're currently using? Like, what kind of data are you using to base your health and well-being initiatives on? Just raise voice. Yeah, staff engagement service, EAP reports, anything else? Yeah? Yeah, okay, yeah. Exactly, so these are all great examples. So EAP reports, medical claim reports, which I'm going to mainly talk about, employee engagement service, participation reports can be something, or HRA, so health risk assessment reports, which might come through apps that you're using, platforms that you're using, etc. So where do we get these reports from, which is the first question that we kind of have to address. And when we're responsible for the health and well-being program, which some of you are, most of you are, or at least you're interested in it, it might be useful to think about who in the company might have data and might be involved in implementing those health and well-being initiatives. So as we can see, there might be lots of different areas, like, for example, human resources. So human resources might be might have some data, absenteeism data, for example, but they also might be involved in implementing certain initiatives like HR policy changes or communication and education. Work health and safety. Work health and safety is very important when it comes to well-being programs as well, because they already have a quite big platform within the organizations, and so this can be used as a place to start. But also there's well-being pieces that are oftentimes overlooked, like workplace setup, condition and equipment, how the place is kept clean, what the state of the equipment is like, all these things can play an important role in your health and well-being initiatives. Employee benefits, the benefit design that you have, the insurances that you might have in place for your employees, and very important, the communication about the benefits, because that's often a barrier. Do people actually know what's available to them? Risk managers. So risk managers can be very helpful because what they do is they look at data a lot. So they can help you to analyze the data, and especially when it comes to medical insurance, which should be micromanaged. And then the local insurers, if you have a multinational, if you work for multinational companies, it is very often that we have a global strategy, but that the health and well-being initiatives happen on a local level. So because of cultural, financial backgrounds that have to be considered when you're putting things into place. So these are the kind of different areas of the business that we have to think about that might be involved, but we also have to think about the bigger picture. So why it is important to make data-driven decisions when it comes to health and well-being. And a lot of you have probably heard about the term medical inflation. I don't really like the term inflation because the medical trend, which I much more prefer, is not only dependent on the inflation of a currency. There's so many different areas that influence the medical trend. And each year there's a few consultancy firms who put out a survey that gives us information on the medical trend across the globe and what the expected medical trend is across the globe. And we can see that the E7 countries have a higher medical trend, which kind of makes sense. So how much more expensive will healthcare be? And the G7 countries have a bit of a lower medical trend each year, but an average is always like around 10%. So when you think about this, if your healthcare gets more expensive by 10% each year, that's unsustainable, right? It's really unsustainable. So we have to find ways to manage costs in healthcare. And there's a few factors that are influencing this medical trend. It's an aging and ailing population. So we get older and we get ill. We live longer but with poorer health. There's new technologies. A lot of new technologies in medicine are more expensive as well. Patient demand, we as patients want more. Provider practice patterns. So there's a few examples that I could tell you. For example, in Hong Kong, doctors only have like a 2-3 minutes amount of time to see someone. So they make them come back. They make them come back more often, which also means that they get more money for each consultation. And they only provide 3 days worth of medicine. So the patient has to come back to get more medicine. So this is just an example from Hong Kong to show you what I mean by provider practice pattern. Shift from a public sector. The public sector obviously sees the same trend as the private health insurance sector, so there's a shift over. They have to lower the benefits so it comes over to the private health insurance. And the change of burden of illness. So I said we live longer with poorer health. There's a spread of non-communicable diseases, and there's a rise in premature death due to these non-communicable diseases. So we come from the perspective of a health insurer, a health reinsurer. So we want to understand the data. We want to understand what the medical claims are like, because we have a few different goals. So one of them is definitely we want to support employee health. Like, we want to help our clients to support their employee health. But we also want to manage the claim experience and thereby manage the costs for our clients, because we want to keep the premium as low as possible. So what we're trying to do is we're trying to identify trends and cost drivers to find the root causes that's driving the costs up. We're trying to interpret these findings and find find solutions that address these issues. So, and these have to happen on a local basis, because the benefits that you have in UK are going to be very different to the benefits in the health insurance in Mexico, for example. There's also a lot of cultural and financial differences, as already mentioned. So what we're looking at, and I'm not going to go too deep into this, but we've created a dashboard that gives a very, very detailed insight into the medical claim data that we receive from country to country across the globe. So we look into the membership type, so that means we're looking into benefit categories, we're looking into outpatient or inpatient service, so hospitalization or outpatient service. We're looking whether it's dependents or it's employees. We're looking into diagnostic chapters, so illnesses, ICD-10 chapters and subchapters. And we're also looking into the provider network. So most of the times the insurers will have a preferred provider network. So certain discounts have been arranged between hospital groups or clinics, and these are the preferred providers. So there's a bit of an opportunity for us to manage this network as well. So there's a wealth of data that we receive, so we can understand whether it's large claims, so expensive services, large claimants, which are catastrophic cases that we can understand. We can also understand whether the frequency went up. We can understand whether the unit cost, so the service cost itself, went up. So we can dig really, really deep into the data that might sound a little bit boring, but it's actually quite interesting what we find, and you're going to see that in the case study that I'm going to present. So once we've understood the data, so once we've digged into this data and understood what really is driving our costs, we try to find health and well-being initiatives that address these main cost drivers. And we believe in a very holistic approach, and we've heard this joined up well-being quite a lot. As we come from a health insurance perspective, there's actually four areas that we see our strategy in. And the first one is stay healthy. So we want to prevent things from happening. We want to prevent illness from happening. So primary prevention programs that help people stay educated to manage their health. So that can be educational sessions, health screening, biometric testing, vaccinations, for example. We then also have the return to health area, so people who have fallen ill and come back to work, or we help them find the right treatment through second medical opinion services, for example, or help them and support them and their family pre, during, and post-hospitalization. Maybe there's EAP services in place, return to work programs that can be implemented. And the last one, and that is one that is definitely the most personalized, is managing chronic illness. So if we have a member, an employee who is chronically ill, how can we support this member? So these are more complex interventions that, as I said, are usually very, very personalized. And these initiatives may vary from country to country, again, depending on the scope of cover in each country and legal, financial, and cultural limitations. And then there's a fourth piece that we look at. So 3 areas that really target health and well-being, and 1 area that is leveraging the health plan management. So how can we design the benefit of the private health insurance to, well, on the one hand, have the best benefits possible for the employees, but on the other hand, also have it as a cost-effective benefit for the company. So this can be that we put member cost sharing into place, so deductibles, co-insurance, co-payment options. As I mentioned earlier, this can be network management. So do we tailor a network for certain companies in a particular way? Do we tailor the network for certain diseases in a certain way? Medical case management, including pre-authorization processes. Claims administration, member service and support, educating our members how to best use their plan. Anti-fraud and waste and abuse programs. So I've mentioned the example from Hong Kong. This is, for example, something where our local insurer could intervene and try to change these practice patterns. So I promised there's going to be a case study. So we've been lucky enough to travel to Thailand in January, and we really dig deep with our insurer in Thailand to understand what we see in their claim data. So we focused on diagnoses, so diseases that we see in the data. We focused on the population. Is it dependents or employees themselves? And we also had a look at the plan management opportunities. And I've just highlighted a few areas here that I want you to have a look at. So we have IP, hospitalization for flu and pneumonia, which I can understand for pneumonia, but if flu comes up there, that always makes me curious. Why is somebody hospitalized for influenza, unless it's a very, very serious case? In total, respiratory claims made up 23% of the total paid claims in 2017. So that's a lot. Almost a third of our total claims paid was for respiratory illnesses. That is a lot. And influenza and pneumonia made up 37% of the respiratory claims. In terms of population, it was mainly dependent children. So at first glance, we only see whether it's going to be employees or dependents. We have to dig deeper to understand that it's actually not spouses, it's children. So just to keep in mind, it's children. And they made up 60% of the hospitalized claims in this area for flu. So 60% of those who've been hospitalized were children for flu, and 77% were children for pneumonia in hospital. And then the last bit, it was low-cost hospitals. It was admission during evening hours, so after work hours. And the third thing is that only a few clients in Thailand cover outpatient services, so normal GP visits. So looking at that, do we have a brave person who wants to give some ideas on how we could address this issue? Yes. Oh, yep.
What's happening is the children are getting sick in the evening and they're just rushing to stay.
Yep, exactly. Very good. Any more ideas of what we could do? Any idea about why there might be admission during evenings and... Yeah. Yeah. Maybe I should give you, that's a great point, maybe I should give you a little piece of information here as well. This client, this particular client that we've been working with has mainly blue-collar workers in Thailand. So they work in a production chain. Those people can't get away from their workplace unless HR would put certain procedures in place to give them the ability to leave their workplace. So yes, yeah. Another idea? There was somebody raising the voice over here.
I'm just thinking respiratory generally. Are they parents smoking around them?
Mm-hmm.
Is there some sort of need for that?
Yeah, definitely. Good thinking. So as we're like running out of time, I'm just going to show you a few ideas that we came up with, and you've already mentioned a few of them. So we have the OP services, so introducing OP services. We said, well, you have a family day in place in your company. Why don't you make it a family health day and bring nurses on site to actually vaccinate your children rather than only your employees? Because vaccinating, flu vaccinations for the employees might be an initiative that is in place anyways, but the employees aren't the problem here. The children are the problem, if I can say it that way. The children are the problem. We had the HR policy review. Yes, how can we enable people to get away from work, to take their child to the doctor during the day, expanding to outpatient service? Because obviously there is some way, they found a way to take, to bring the kids to the hospital. And there's another opportunity. It was low-cost hospitals that the children are taken to. So they have an initiative to fill beds, right? So we have, as an insurer, have to manage the hospitals so they don't just hospitalize children overnight just to make money. Telemedicine is another idea. Education and awareness campaigns about smoking, especially, for example, pre-authorization processes or triage services for respiratory illnesses, and the exclusion of low-cost hospital for specific diseases. So just a little insight, and yeah, just summarizing this: identify your trends and cost drivers, interpret the findings, use the data available, and find the right initiatives that address the cost drivers. Thank you very much.